Haemostasis is the normal physiological response to vascular injury and is designed to control bleeding at a site of injury. The most common defects of haemostasis are acquired, for example, due to medication, infection, or other medical conditions. Whilst less common, it is important to recognize inherited bleeding disorders in order to provide optimal care to people with these conditions and prevent excessive or abnormal bleeding. Primary haemostasis is associated with the initiation and formation of the platelet plug. The aim of primary haemostasis is to quickly stop bleeding. The endothelium plays an important role during this process through collagen and von Willebrand factor. Upon vessel injury, collagen is exposed and von Willebrand factor is released by endothelial cells, which attract and activate platelets to form the platelet plug. Secondary haemostasis, or the coagulation cascade, is associated with the activation of coagulation factors. It is separated into three distinct phases: initiation, amplification, and propagation, leading to formation of fibrin strands and a stronger clot. In normal haemostasis, a stable blood clot is formed within a few minutes. Deficiency or dysfunction of any of the elements of primary or secondary haemostasis can result in a bleeding disorder. The activity of coagulation factors in secondary haemostasis can be measured using blood tests and, along with the clinical history, helps to determine the underlying bleeding disorder. Coagulation testing is sensitive to the impact of pre-analytical variables, such as caffeine intake, stress, some medications, vigorous exercise, and sample handling. These factors must be taken into account when interpreting results. The basic clotting screen includes the prothrombin time, or PT, which is sensitive to changes in the activity of factors prothrombin 5, 7, and 10. The partial thromboplastin time, or PTT, also known as activated PTT or APTT, is sensitive to changes in factors 8, 9, 11, and 12. Where the PT and APTT are both prolonged, this suggests deficiency in factors prothrombin, 5, 10, or other combined deficiencies. The PT and APTT are not sensitive to deficiencies in some rare coagulation disorders, such as factor 13 deficiency, nor are they sensitive to disorders of primary haemostasis. For a definitive diagnosis, specific factor assays are performed. This video shows examples of two bleeding disorders, von Willebrand disease and haemophilia A. Von Willebrand disease is the most common inherited bleeding disorder affecting mostly primary haemostasis. Patients with type 1 or 2 von Willebrand disease may have normal PT and APTT values. However, measured von Willebrand activity will be reduced. Von Willebrand factor is also a carrier protein for factor 8. Therefore, patients with more severe types of von Willebrand disease have a prolonged APTT due to low factor 8 levels, affecting secondary haemostasis. The diagnosis can be confirmed with von Willebrand factor testing and genetic testing. Haemophilia A is the second most common inherited disorder after von Willebrand disease, affecting the coagulation cascade or secondary haemostasis. Without sufficient factor 8 activity, the blood cannot clot properly to control the bleeding. Laboratory testing shows prolonged APTT values due to low activity of factor 8, and the diagnosis can be confirmed with factor 8 testing and genetic testing. It is important to recognize and understand the origin of the bleeding to ensure proper diagnosis and optimized care. For more information, go to core2ed.com.